Good afternoon, ladies and gentlemen. Great pleasure being here on the first day of C3 2018. I'm with Pradeep Arumugam, who is the Director of Interventional Cardiology Program at East Carolina University. And my name is Ramesh Daggubati. I'm the Associate Chief of Cardiology at NYU Winthrop Hospital in New York. So Pradeep, what do you think about our fellows course that has happened this morning and continuing on?
So far it's been excellent. It provides a basic foundation, which is what I think we should start off with. We had talks on FFR, radiation safety, dual antiplatelet therapy. It's been going very good so far. And there's been a lot of attendance. There's been standing room only.
Right. And you have talked on FFR and IFR. Could you please elaborate on how you use FFR in your clinical practice?
So I use both FFR and IFR, but not at in the same time, because I work in two different hospitals. One hospital only has an IFR, FFR control, and the other one has an IFR control. So in the hospital where there is both IFR and FFR, I usually do a IFR. The majority of the situations is obviously for intermediate stenosis, and then occasionally for bifurcation stenting, where you want to know if the diagonal needs to be stented or not. These are the usual situations I use it for, and more commonly I've been using it for left main, especially ostial left main, to determine the physiologic significance of the stenosis.
So can you please elaborate on your research on FFR, where you have published as a fellow or a cardiology resident? So
the research that I published on was for using regadenoson for FFR. So I was a cardiology fellow at that time, and then I thought, if you're doing regadenoson for stress testing, which has the same idea, why not use it for FFR? And we published it on 20 patients, and it was pretty equivalent, and it was published in Neurointervention at that time. The main advantage for regadenoson is, one, it's a simple IV push, and the results are much quicker. With adenosine, with this study, what we noticed was it came out at around 1 minute 15 seconds or 1 minute 30 seconds. For regadenoson, it came at around 45 seconds. The disadvantage, though, it was fleeting. I mean, you cannot use it for diffuse lesions or multiple lesions. And there is no study that has been shown to be used for multiple injections. I mean, you can use it for one time, but hopefully there will be some study where you can use it for multiple times. And then the other thing I would be interested in doing is to do intracoronary regadenoson to see what would be the difference. But for that, you would need to do a dose ranging study first.
Yes. You mentioned adenosine and regadenoson. Both of them are inducing hyperemia, and that is the fractional flow reserve using hyperemia. And what is the cutoff value for FFR?
FFR would be 0.8, and I'm guessing you're going to ask me for IFR would be 0.89.
Yes.
So again, these are not dichotomous variables. If 0.81 does not mean it is 0.81 is normal, considered normal, but 0.79 may not cause that much damage either. It depends on where the lesion is. If it's left main, and if it's 0.79, the impact would be much higher than a distal RCA with a 0.79.
And what is the main difference, you think, between IFR and FFR?
The main difference in IFR and FFR, I think, is the use of the hyperemic agent. It's much quicker. The patient doesn't feel as bad. But there are still a lot of controversies in FFR and IFR, which has to be teased out over the next few years.
Okay. So in IFR, there is no hyperemic agent that is used. In FFR, we are using adenosine or regadenoson as a hyperemic agent. And there's probably cost effectiveness with the IFR, you think?
The regadenoson, one vial alone costs $110 in most places. So that by itself would be reduce the cost in total. And discomfort to the patient too. With adenosine, you have to wait 3 minutes, and patients are way more susceptible to heart blocks and complications with adenosine.
You have also mentioned different types of subsets, bifurcations, diffuse lesions or serial lesions or left mains. Do you think that the FFR or IFR one is better than the other?
With the IFR, there is this thought process that you can co-register with the cinefilms and see exactly where the IFR drops off a whole lot. So that has not panned out in the clinical practice, even though the science is there. So unless somebody comes with a big study, I do not think there is any significant advantage on lesion subsets. Even though the IFR people say there is, unless there is a big study out there that shows that, I'm not going to follow that yet.
What do you think the role of FFR is in bifurcation lesion as such?
Bifurcation lesions, obviously, the significance in the main branch or the side branch would be important. But more importantly, the way I use it is after you stent or angioplasty the main branch, if the side branch, it always looks a little smaller after you have done it. So then I put the wire down into the side branch to look at the physiologic significance. And only if it is physiologic significance, I consider doing stenting or angioplasty.
In your practice of interventional cardiology, say for example, you do 100 patients, how many of them get FFR?
I believe in FFR a whole lot, so I believe in physiologic testing, so that means I do end up doing a lot of FFR and or IFR. I cannot give you an exact percentage, but I'm pretty sure it's more than 50%.
Do the rest 50% present with acute coronary syndrome or with previously performed stress testing as an outpatient?
The majority of them are acute coronary syndromes. The ones which have previously performed stress tests, unless I think it appears physiologic significance, I would stent it. If it does not, then I would still consider doing an FFR. Now, it's a class 3 indication to do FFR on a truly positive stress test, but we rarely get this truly positive stress test. We always consider this as breast attenuation, diaphragmatic attenuation, etc.
What about the role of right atrial pressure on measurement of FFR?
So the right atrial pressure, the original formula, there is the issue is we ignored the right atrial pressure or LVEDP because we do not know which one is the true value to use for the original formula. But there are studies out there that show that it does not make much of a difference, but some of them it does. I truly believe if the right atrial pressure is 25 or markedly elevated, then I would consider fixing that first before we do an FFR. But then there are going to be some patients who have chronically elevated right atrial pressures. How do you deal with that? That I'm not sure.
One last question is about AV fistulas or high output flow states and the measurement of FFR or IFR.
See, the high output flow states should be, it is not coronary circulation though. It is going to be in the, for the cardiac output, and it does increase your myocardial oxygen demand, which by itself could increase the flow in the myocardium. In those cases, I would prefer FFR over IFR only because it will maximally dilate the arterioles. But again, these are just anecdotal experiences. I don't think there is any study out there that shows if one is better than the other.
And finally, FAME3 has not been published yet. Has not been completed enrollment yet. But what do you think that in FAME3, where PCI versus bypass surgery based on FFR will reveal? So
there was a reasonably big study done before with 100 patients in which, but this was retrospective in the sense, what they did was they did a FFR, they did angiogram on everybody and did FFR on every single lesion and sent them for bypass. And then a year later, they went back and did an angiogram, and they saw that everybody who had, wherever the bypasses were put for FFR less than 0.8, the bypass stayed open. There were only 8 to 9% bypass grafts were occluded. But if it was more than 0.8, 25% of them occluded. So the chances are I don't know how good an answer we're going to get from FAME3, but I suspect that our FFR-guided revascularization, even for bypass, should be better. But will it show a mortality benefit? Who knows?
Yes, I think we might need a much long-term
And larger
follow-up
study
for all these patients with the FFR-guided revascularization. Now, what do you think about the FAME2, which is the medical therapy versus FFR-guided PCI?
So for FAME2, obviously the main disadvantage of FAME2 was it was stopped early. I think the study should have been continued. There were increased revascularization. It did improve your hospital readmissions. Still, it was not, if you were a patient and you were told that you had stenosis, okay, your revascularization is going to go up because you're going to come back and tell me that, yes, I'm having chest pain, and you will end up having, so I don't know what to interpret from FAME2 other than the fact that it did improve hospital readmissions.
Right, in the absence of negative cardiobiomarkers, whether we should just go with the patient's perception of chest pain, especially after being told that they have coronary artery disease, is difficult.
Because in practice, you and I have met patients who would come and tell you that I have an 80% lesion, needs a stent.
Yes.
You know, and you're forced to do a stent in some circumstances, even though we all try to avoid it.
Thank you very much, Pradeep, for your time, and
Thank you.
welcome to C3. I hope you have a wonderful time here.
Thank you.
Thank you.